right, good afternoon, everyone. Amir Abdul, Jabbar. I'm one of the orthopedic surgeons here at Swedish. Last lecture of the day, you're almost there. So going to be discussing multi-rod constructs. Let me take myself back to the beginning here. And this is something that I've kind of seen quite a bit of here. We get a lot of complex revisions at Swedish, and there's not a whole lot of data out there to support it, although there is starting to be some. So I thought it was an interesting topic in terms of teaching these techniques that are used in pretty isolated situations for a variety of different reasons I'll talk about. But I thought it was interesting to actually look and see how much support there is in the data that we have gathered. And then also some of the techniques that, there is no data surrounding, but if you do get into a tough situation, you may want to know. So looking at how many rods is enough, this is kind of one of our more traditional AIS type cases where not a whole lot of screw density here. But you do have hooks at the top. You've got just 2 rods, not a lot of screws. You get good correction. And these patients seem to do pretty well. So, why use more? Obviously, a lot of people are doing more hardware for these type of cases, but in a healthy young patient with idiopathic scoliosis, this may be enough. Here's another type of case where, an additional 2 rods are placed to give that extra fixation. Not a kind of crazy construct, but you do have a lot more rigidity at that lumbar spine across the sections where there are 4 rods. We'll talk about some of the reasons you might want to use these. Here's another case that I was able to look up. We've got 4 iliac screws, kind of lots of screws all over the place. And what are the kind of cases where you might want to try and create something crazy looking like this? And then here's a case where you've got 10 different rods. And I'm not sure, what the reasoning behind this was. This isn't one of the cases that we had. But if you are going to be using multiple connectors and rods in different locations, what are you actually trying to achieve with that? So some of the indications, again, there's no real hard and fast rules for any of these constructs and when you may need them. A lot of times it's a revision that's gone wrong and there's an area of pseudoarthrosis and you want to reinforce that area, so you really want to focus your extra rigidity from your construct across that pseudoarthrosis. But sometimes when you may want to think about doing this as a primary surgery, a lot of the literature out there we'll talk about a little bit more coming up is in the case of 3-column osteotomy. And some of the data that you may look at looks at the early results in terms of pseudoarthrosis, pain, hardware failure at 2 years, but sometimes with these 3-column osteotomies, they're happening at 6-7 years out, and unless you have a really robust data set with good patient capture, you can say, I have great results with 2 rods and, why use 4? But for the people that really do these often and are able to capture their patients, they're seeing that those pseudoarthroses are happening much later than you might imagine. Tumor cases, in cases where you're actually going to be resecting that entire anterior column, I think that's a case where you may want to have some extra rigidity at that place, where whether you're doing a good anterior reconstruction, which you should be doing, but is that going to be enough to supplement the entire construct and have a rigid neutral spine going forward? Charcot arthropathy is one of the times that we've used it here. I've seen quite a few cases where patients may not be obviously symptomatic. They may be paraplegic and come in with a terrible looking broken construct with what looks like an infection, but nobody really understands why these patients end up with these large pseudoarthroses. But it seems that if you do add extra instrumentation and extra rigidity to these constructs, and you may have to if they come back and they've failed, but if you were to do it primarily, you may not have to end up doing as many revisions. These patients are usually very asymptomatic, but they may have a change in posture that brings them in, and you've found that their construct has fallen apart completely. So they're definitely a setup for needing extra fixation and having an increased rate of revision. Neuromuscular deformity is another one. Probably want a stronger construct because again, no one really knows why, but maybe a lack of core strength above your construct can put extra stress. So if you have a healthy patient that has a really good paraspinal musculature, they may not need that extra fixation, but if you are doing someone that has a neuromuscular with core weakness, then they may need more rigid construct than just a normal 2-rod that we would usually do. And it's kind of something that I've heard talked about before, but in severe osteoporosis, obviously we'd want to just treat the underlying problem. But in a case where you may not have time, they may have an acute onset neurologic deficit, the extra rigidity in a osteoporotic patient may be another indication for multi-rod construct. Again, I said most of it focuses on the PSO. We'll go through some of them here. There's also some anatomic studies that give pretty strong evidence to support it in cases where it's indicated. Again, I don't think this is something that you need to do for every single lumbar fusion that you do or thoracolumbar, but there are settings where it's pretty helpful. So this is a study looking at anatomy with multiple different rod constructs. So it's a biomechanical study, L3 PSO. They only did L1 to S1, and then they tested it for mechanical strain. And just going through the different orientation, there's titanium 2-rod, titanium 4-rod, cobalt chrome 2-rod, cobalt chrome 4-rod. That's a whole different discussion in and of itself, which we'll save for another time. But then they've added to those constructs a spacer. They did a lumbar interbody peak spacer above and below the PSO. So the 2 rods plus the spacers, cobalt chrome, and 2-4, and all those different constructs. So I thought this was a pretty interesting study because looking at the findings with over on the left are traditional titanium, and then cobalt chrome is the third from the right. You do see more flexion extension motion. And then actually the least motion was with the 4 rods with the spacers. But if you also look at 2 rods, titanium rods with spacers, that's actually less than cobalt chrome 4 rods. So again, it's a cadaveric study. I don't know how much you want to gather from that, but there's actually quite a bit of rigidity that you can add to your construct just by putting 2 spacers above and below your PSO, which may be more effective than adding a whole set of second rods. Obviously, in the setting of PSO, you want it to be as rigid as possible, so if you're going to do it, maybe go for the whole kit. But something also to consider is that it's not just extra rods that are going to create stability, it's that anterior column and making more rigidity, taking away the motion of the disc above and the disc below that can actually give you a much more rigid construct. This looked more at the surface strain, and again, the data is as expected. You add in hardware, you have 4 rods sharing the strain. There's much less strain on those primary rods than if you had secondary. But as I said before, the spacer added quite a bit of reduction in strain compared to just the rods in and of themselves. Sorry. This was another cadaveric study and looking at bending moment and stress, but they used a little bit of a different orientation. So this was actually focusing on what they call a delta rod. So if you look at these 2 constructs here at the bottom, it's mostly looking at the lateral. So in the cases that we've used extra rods, you may do a PSO and you have 4 rods here at the middle. You can see where that PSO is done, and they have the 4 rods that are just limited to that space, which is an interesting approach to it. It does give you that localized extra rigidity. These with longer setups, and Here and here, you can see that this was what they call a delta construct. So rather than having the rods go in contour with the actual lumbar lordosis you're trying to achieve, you have a straight rod coming down in more of a kind of kickstand type setup, whether using 1, 2 crossed, or 2 straight. And then they looked at those in terms of strain and bending moments. And again, not surprising that by adding in more metal into your construct, you're going to have less strain on the primary rods, less bending. But actually, and so this, where's my pointer? So this is the delta, single delta and double delta, and the crossed. And obviously, these are, if you think about the biomechanics of it, they're much stronger in terms of reducing flexion and bending and all the other testing that they did. And it makes sense because it's out of plane, and so you're actually adding a whole different vector of rigidity to the construct. And whether that's going to be proud and cause problems in terms of hardware prominence, maybe unlikely, especially in the case of the PSO where it's a very steep correction and you've got a hard angle there. But it's something to consider if you are going to consider doing these type of constructs. Going to more clinical stuff, this is a retrospective matched cohort where they looked at 66 patients in each group and then 2-year follow-up. Again, we had a mean of 7 years, but the minimum was 2 years. And then they only used plain x-rays to look at these pseudos. But it was one of the few clinical studies that we have. And just going straight to the kind of more important part of this finding is looking at radiographic pseudoarthrosis, and then in a 2-rod construct versus a multi-rod construct. At the osteotomy site is where the vast majority of the pseudos are, but a 3-fold increase in terms of pseudoarthroses at the osteotomy site when you add in multi-rod constructs. And it's worth noting in this one that they counted both 3 rods and 4 rods as a multi-rod construct. Anything more than 2 was considered multi-rod, but they did show a significant decrease in terms of their pseudoarthroses. Another similar study, but this was just looking at the lumbosacral junction. And again, if we look back at our historic data, that's the most common place in a more traditional type fusion that you would see a pseudoarthrosis is at that lumbosacral junction. Again, not the best follow-up 1 year, 15 dual rods, 16 multi-rods. Worth noting that all these patients had BMP, so that was standardized across both the cohorts. And these had a CT follow-up, so a little bit better in terms of actually qualifying that pseudoarthrosis when it did happen. But again, not surprising, but good data to show that in their multi-rod setup, they had no rod fracture, no 5-1 pseudoarthroses, and again, this is short follow-up, so I think if you were to follow these patients out to 6 years, you would probably see more in both groups. But even at just a minimum of 1 year follow-up, that's a pretty significant difference in terms of the 2 cohorts. And then the one downside to this, so if we consider, okay, we've got a patient where you're doing a big revision, you have a PSO, you want to use 4 rods instead of 2. It's not necessarily that the entire construct is better. It's going to also put a whole lot of strain on your most caudal fixation. So this looks specifically at the iliac screw loosening after spinal deformity. And 51 dual versus 51 multi-rod, 55 versus 51 multi-rod constructs, and 42 months was the mean follow-up, so not as long as we would hope for. No significant difference in terms of ODI. So if you're looking at outcome measures, you could say that's the most important factor. There's no real difference, but there was a difference in terms of what you're finding looking at your 2 constructs and how they turn out radiographically. So not a lot of difference between these 2 groups. Again, our main finding down at the bottom, looking at the screw loosening and rod fracture. So these are our important numbers here. in these four squares, you've got 9% of iliac screw loosening if you use two rods, and then almost 40% in the multi-rod group, and then the numbers are almost perfectly flipped if you switch them to your rod fracture versus four rods in multi-rod versus two rods. So it may not be that we're getting rid of complications, that you're just kind of switching one complication for another. People may argue that it's more important to have a strong fixation across the area that may be weakest, rather than worrying about your iliac screws loosening, which can be replaced. And again, most of these patients do well in terms of their ODI either way. So other considerations: age, core strength and bone quality. Again, things that you can preoperatively optimize if you have the opportunity to bolster your patient in terms of their physical health and their bone mineral density. You may not need to do this, but if those are problems that you can't avoid and you do need to go ahead and do a surgery, whether it's a acute revision or someone with neurologic deterioration, those are times that you may want to bolster your construct. And then the stability itself, where is the case? So if you're crossing the thoracolumbar junction, you may need a little bit more stability. Operative planning, are you planning on doing a PSO or a vertebral column resection? Those are the cases where I would very seriously consider. And in revisions, where is your pseudoarthrosis? Where was your rod fracture? Take the extra time to give more fixation across that area. Some of the implants that we've been using have made this a lot easier. We used to have just traditional side-to-side connectors up here in the upper right corner and using normal rods. It's made it a lot easier looking at these kind of multiple screws where you have two heads set up side to side can make the actual execution of this plan a lot easier if you have one of these opposed to just traditionally we would have to alter the angulation of your screws when you're putting them in. So keeping a set of screws medial and knowing that you're going to have more of a straight ahead trajectory versus keeping it more lateral with more of a lateral medial trajectory can give you the room to place these multiple rods. Or you can take the easy way and just use one of these multi-head screws. So some of the considerations that I talked about when you're doing your pre-surgical planning, and I've seen some of these myself. This is just looking at if you are using a dual head screw or a side-to-side connector, either one, where you're going to want your rods to be. So this is what's more traditionally used if we would have a PSO at this level. So if you can imagine that this is either a corpectomy or a PSO, you're going to want to focus your increased strength across that site. So these would be an outrigger type rod, and then your longer rods can fit right in there without having to do too much extra work. And again, the dual heads or a side-to-side connector can allow you to do that. The dual heads do offer a little bit more rigidity because there's no rotation from one rod to the next. This is another setup that I've seen some talks with Larry Lanke, which is kind of the way that he likes to do his constructs now. And he'll use dual-headed screws at S1 here. So he's got 4 rods at the bottom. And this is imagining that there's a PSO here at 4 or 3. And then you go to 3 rods during this area, and then if it's a long construct to the upper spine, you're actually slowly decreasing the rigidity rather than having an abrupt transition from 4 to 2 rods here. It goes from 4 to 3 to 2, which in theory may prevent some PJK, a softer transition into the thoracic spine. Again, there's absolutely no data to support any of this, but in theory, it does sound pretty good. And I've seen his constructs, they look pretty good. Just some of the cases here that we've done here at Swedish, and I'm just going to show you another intraoperative photo as well. This can be hard to see, but right down here at the bottom, you can see this short rod where there was a PSO completed there. And again, that's focusing your maximum rigidity right at the area of where there's possibly the weakest point and the most likely to have a pseudoarthrosis. This person was then so converted into a longer construct. You can see there's side-to-side connectors in the Z-rod, lots of fancy, expensive hardware used in this construct. Another one here where the patient was extended from a lumbar fusion to a high thoracic fusion. And looking at the 4 iliac screws, this one has, if you look specifically down at the bottom here, so we've got 4 iliac screws that kind of bridge into the upper construct. And then here is the thoracolumbar going from the the lower thoracic spine into the S1 screws as almost 2 parallel constructs working together. Again, many different philosophies. All the data we see just calls this a multi-rod construct, even though it's a completely different philosophy from the last one. They would all be thrown into the same bucket. So I think we should look a little bit more closely at how those cases differ from one another. But I think it's also important to know you want that side-to-side connection within the different constructs to really give it the maximum rigidity. And this was the delta construct I was talking about before. This is using just 2 medial rods with side-to-side connectors, but maybe instead of using the contour of the lumbar spine where there was the PSO done, you can do just straight rods, and that gives you almost a kickstand effect and a lot stronger construct in that space. So concluding here, consider this in the patients where, you're involving the anterior column, corpectomies, 3-column osteotomy, vertebral column resection. No studies looking at those cases specifically, but it does seem that if you are involving the anterior column, you're kind of setting yourself up for a pseudoarthrosis if you don't add the extra rigidity. Preoperative comorbidity, neuromuscular scoliosis, Charcot-arthropathy, again, cases where you really want to consider using these constructs. And don't forget that your interbody spacers are something that are kind of a go-to, but in combination with a PSO, it does add even more stability than adding the extra rod. So if you add the combination of the two, you're really giving your patient the best chance for having a strong fusion after the surgery. And use of the new implants to facilitate the integration. If you don't have access to them, you really want to take the time to make sure you plan out your screws and don't have to struggle with those rod placement, because it can be difficult if you don't have those specific implants. So that's it from me.